Question 52. Which of the following is the most likely origin of this patient's symptoms? Autonomous catecholamine secretion, autonomic neuropathy, mineralocorticoid, ACTH. All right, so this is sounding like it's probably an endo question. A 35-year-old woman presents to her primary care clinic complaining of episodic pounding, headaches, palpitations, and sweating spells that have been occurring intermittently over the past 2 months. Each episode lasts about 10 to 20 minutes and resolves on its own. She also feels anxious and jittery during the episodes. She has no significant past medical history and takes no meds. Her father had a surgery for a gland in his neck in his 40s. Okay, so that the age is very important. The younger, the scarier. On physical exam, her blood pressure is 168/96, and she's tacky, mildly anxious. So she's got a lot going on for her. Which of the following is most likely diagnosis? Again, let's start. I guess we'll just start from the top. I'm going to mix it up. Let's start from the bottom. Inappropriate thyroid hormone secretion. So inappropriate thyroid hormone secretion, inappropriate meaning probably maybe a thyroid tumor or Graves' disease, something where we're hyperthyroid. Hyperthyroid increases our basal metabolic rate. So it's totally possible to see higher blood pressure because thyroid hormone works on the heart. Same thing with tachycardia. You could have anxiety because of those symptoms, palpitations, sweating spells. Sure, why not? And her father has a gland in his neck in his 40s removed, or something happened to it. So I'm not going to rule this one out. I think this one's pretty solid. Let's keep moving on. Even if you're pretty confident on a question, I always look at all of them just to make sure there's not one that is a better answer choice. ACTH secreting pituitary adenoma. So ACTH would stimulate the adrenal cortex to start making its hormones. If you don't remember the adrenal cortical layers and the hormones it secretes, just think go find Rex, make good sex. So G would be the glomerulosa, F fasciculata, R reticularis, and then each letter of the second half of this phrase corresponds to each letter of the first three. So mineralocorticoids would be from the glomerulosa, glucocorticoids from the fasciculata, and then the sex hormones from the reticularis. So we would definitely have a lot of glucocorticoids, so cortisol. We might get some more sex hormones, so more androgenization in a woman. She might start getting facial hair, acne, and so on. Mineralocorticoids, maybe a little bit, but probably not a ton, because mineralocorticoids like aldosterone are primarily stimulated through RAS, not as much ACTH secretion. And it would be aldosterone that would be primarily responsible for things like increased blood pressure. Either way, really none of these would explain all of the other like sympathetic findings she's having, the tachycardia, palpitations, anxiety. So I'm going to cross this one off. Mineralocorticoid secreting tumor is pretty darn similar to D, and we just talked about it. So aldosterone itself could account for the blood pressure and maybe even the headaches from blood pressure, but it's not going to account for everything else. And it's definitely not going to be episodic. Episodic is really important here. Aldosterone is going to cause a lot of sodium and water retention, and that is going to be essentially a permanent process. It's not going to be 10 minutes on, 20 minutes on, and then gone. You're not just going to unload a bunch of water and then get rid of it all of a sudden. So we're crossing this one off. Autonomic neuropathy due to undiagnosed diabetes. Autonomic neuropathy. So like she's got crazy sympathetic tone. Autonomic neuropathy from diabetes could happen, but it's usually the opposite direction. It's usually not extra sympathetic tone. It's usually not enough sympathetic tone. So that's where you might get things like orthostatic hypotension. We actually had a question on this earlier on in the question bank. We actually had a question on this earlier on in this practice test. So this one's out. Autonomous catecholamine secretion, or in other words, a pheochromocytoma. Well, catecholamines refer to epinephrine, norepinephrine, dopamine, and we know that stuff definitely causes hypertension and tachycardia and anxiety, right? That is the definition of sympathetics. And that's exactly what she has here. She's got headaches, palpitations, sweating, jittery, anxiety. That's all sympathetic tone. And they're only in 10 to 20 minute episodes. And that's how pheochromocytomas work. They're periodic releases. Periodically, the tumor will release its hormone. It's not a constant release. It's episodic in nature. So this is looking like a really good answer choice so far. How can we distinguish between A and E, inappropriate thyroid hormone secretion? They can both cause elevated sympathetic tone. The major difference is, again, the winner here, episodic, 10 to 20 minutes at a time. That would be our pheochromocytoma, choice A. Inappropriate thyroid hormone secretion like Graves' disease, tumors, they're just constantly making thyroid hormone. So it's not going to be episodic. Pheochromocytomas are known for being episodic in nature. And if you remember your 5 P's of pheochromocytoma, pain, perspiration, pallor, palpitations, pretty sure we have almost all of those here except maybe pallor. So again, the correct answer is A, pheochromocytoma.